Dr. Yvonne Cason, the president of Spiritual Awakenings International. And it is my honor to be hosting our next event. We're going to have two outstanding speakers on supporting STE Experiencers, both of whom are Spiritual Awakening Circle of Honor honorees. And our first speaker is Dr. Alexander Moreira-Almeida, MD, PhD, who it is my great honor to recognize him today and pay tribute on his induction into our Spiritual Awakenings International Circle of Honor, which is our sort of hall of fame for groundbreakers and pioneers in the area of spiritual awakenings. Dr. Alexander Moreira-Almeida has been an outstanding pioneer raising awareness about spirituality and spiritually transformative experiences in the field of psychiatry worldwide. Dr. Moreira-Almeida is a professor of psychiatry, the founder and director of the Research Center in Spirituality and Health at the School of Medicine at Federal University of Juiz de Fora in Brazil. He is the former chair of the sections on spirituality and psychiatry of both the World Psychiatric Association and Brazilian Psychiatric Association. Dr. Moreira-Almeida is the editor of the book, Spirituality and Mental Health Across Cultures, and he is also co-author of the Science of Life After Death. No, Science of Life After Death. Yes, that's correct. So thank you and congratulations to Dr. Moreira-Almeida on your induction into the Spiritual Awakenings International Circle of Honor, and we look forward to what you have to share with us today. Please go ahead.
Thank you very much. It's a great pleasure being here with you. Thank you for the opportunity to share our findings in our research with you and with all the attendees of this meeting. Okay, I will start and will talk about the scientific study of spirituality, and especially about one of the most important spiritual beliefs of most spiritual traditions, the idea that there is some sort of life after death, or some sort of survival of consciousness. And we will, just start briefly summarizing the main findings on research about the impact of religion and spirituality on health. Actually, nowadays, there are literally thousands of empirical quantitative studies investigating the impact of spirituality, spiritual and religious involvement on health. And the most constant findings show that higher levels of religious or spiritual involvement is usually correlated with lower general mortality, a decrease in about 30 to 50% in general mortality, lower levels of depression and faster recovery, lower suicidal behavior, including suicidal death, lower substance use, abuse, and dependence, and higher levels of quality of life, well-being, and human flourish. Of course, there are also some possibilities of negative impacts, especially some sorts of negative religious coping, or, for example, when people refuse treatments because they see some kind of conflict between spirituality and medical psychological treatments. Of course, this can be a negative impact. And based on the high prevalence of religion and spirituality worldwide, and also about the very significant impact of it on health, several medical and other health-related organizations have emphasized the importance of taking spirituality in clinical practice. For example, here, we show the World Psychiatric Association position statement on spirituality, religion, and psychiatry that tells the need and provides some guidelines for psychiatrists worldwide to take into consideration spirituality. And this position statement is freely available in 7 different languages: English, Spanish, French, Dutch, Arabic, and Chinese. They are available at this website in the bottom, religionpsychiatry.org. So for those who are interested in knowing more about this. But one very important issue is what is actually spirituality? What is the definition? There are many different definitions of spirituality, and one of the key definition of spirituality, if we think what there is in common between all spiritual traditions, the most prevalent spiritual traditions worldwide in Hinduism, Buddhism, Christianity, Judaism, native Brazilians, whatever. Usually, one of the core concepts of basically all spiritual traditions is that there is some sort of transcendental realm of reality. And this other reality is actually considered sacred. So the core is that there is a transcendent sacred. So the idea that there is some transcendental reality, basically the idea that there is God, spirit, ancestors. This idea is at the core of basically all spiritual traditions. And this other transcendental realities is considered the ultimate truth or the ultimate reality. Okay? And among these transcendental aspects of reality, one of the most pervasive beliefs is exactly in some sort of afterlife. The idea that we are more than our physical bodies and that we survive in some sense the physical death. So most of the world population nowadays hold the belief in afterlife. Even in the very secularized Western Europe, only 40% believe that when people die, there is the end. There is no life after death. And even contrary to what many people think, in several countries, there is a direct correlation between higher levels of education and higher acceptance of the belief in afterlife. For example, we have data in France, Russia, Canada, and Brazil, showing that the higher the educational level, the higher the belief in afterlife. And also, what are the impacts of this belief in afterlife? There are several studies about the impact of the belief in afterlife in mental health. For example, lower levels of end-of-life despair, lower suicidal deaths, lower levels of anxiety, and lower and higher levels of life satisfaction, because the belief in afterlife seems to impact strongly the worldview as a whole, and also how people see themselves and meaning of life. There are some studies in this sense. So it seems that is important. But that is the point. We know that the belief in afterlife is very prevalent throughout history, and even nowadays. We know that impacts health and well-being. But what is the source of this belief in afterlife? Usually it's related to some sort of spiritual experiences showing some transcendental aspects of human beings. But however, some theories believe that these experiences are just hallucinations, perceptual problems, or because there are some cognitive distortions, psychological needs that make people believe in afterlife, or that they may be social cultural constructions. However, we must take into consideration also that these experiences are actually actual contacts with a transcendental reality, with some larger reality that goes beyond our physical world. And actually, there are literally thousands of studies investigating several spiritual experiences suggestive of consciousness beyond the body, like near-death experiences, out-of-body experience, and so on and so forth. And this is exactly one of the goals of a recent work that we have just published. The idea was to present and discuss the best empirical scientific evidence for survival of human consciousness after permanent bodily death. Many people think that the belief in afterlife is just and necessarily a religious, spiritual, or philosophical question. Of course, it is. But it's important to know that it is also a scientific question. For 150 years, there has been many high-level scientists and philosophers who have investigated scientifically the evidence for life after death. However, before even presenting and discussing the empirical evidence and scientific evidence for survival, it's important to address some misconceptions against the possibility of human survival or even the mind existing beyond the brain. There are several myths that I will not have time today to address, but perhaps one of the most important is this one in the top, that neuroscience has proved that the brain generates the mind. Many people think that it's a scientific fact that has been proved that the brain activity, electrical and chemical activities, generates our mind, our consciousness, our feelings, our thoughts. However, this is not true. What science has shown is the correlation between some brain activities and some mind activity, but not necessarily that the brain produces the mind. The two major options are, one, the brain produces the mind, or the brain is basically a tool, an instrument for mind manifestation. So we need to be open to this possibility. And now let's discuss some of the most interesting experience showing or suggesting the possibility of survival of consciousness beyond death. The first that we'll discuss here is near-death and out-of-body experiences. We know specifically in out-of-body experience during near-death experience, especially in cardiac arrest, when the heart is not beating anymore, when the brain receives no more blood, no more oxygen, glucoses, so the brain stops working. So if the brain produces the mind, when the brain is not working, it was not supposed to have any mind activity. However, people in near-death experience report clearly, very clear consciousness, not only clear consciousness, they usually emphasize strongly that they have been more conscious or have a more clear mind than in usual daily life. So this is very, very interesting. They think that what they experienced is more real than reality. And this experience impacts very much patients' own personality and beliefs after the experience. It increases a lot the belief in life after death and also the belief in spiritual values. And it's very also important that these experiences are not dependent of religious, cultural level, educational level, fear of death. So there is a core nature or core features of near-death experience that are transcultural and transhistorical. There are studies describing near-death experience in China 800 years before Jesus, for example, or even Plato reported a near-death experience case that are very similar to the ones that we see nowadays in the Western world, for example. And there is even some more interesting data about verified veridical perceptions when patients who had a cardiac arrest, they report things that they observed. Usually they say that they are from the ceiling, observing in a different vantage point what is happening, and what they describe there later is confirmed by people that were present. So shows that this not just fabulations, not just fantasies, but actually they were actually active, conscious, and being able to observe and report. So it shows that the mind could be working when the brain is not working. The second type of evidence that is very important is mediumship. People who claim to be in touch with deceased consciousness, deceased personalities. There are several triple-blind protocols that controls for information leakage, for fraud, for several stuff like that. And a recent systematic review with meta-analysis showed that mediums can produce above chance level veridical information. So it's also very important. And we have also conducted in Brazil, in addition to these triple blind protocols, we have produced some semi-naturalist design protocols that try to be more ecologically valid, more in line with the daily practices of some mediums in Brazil. And I present, for example, this case here. This study, we selected about 100 bereaved people who lost their loved ones in the last 1 or 2 years, and they scheduled them to have some meetings with some selected mediums who had previously consistently produced reliable information from deceased people. And in this case, it's very interesting. We have here a couple of parents with a medium, okay? They were together, but what we did, we allowed some kind of interaction between them, but all interactions were filmed. So we were able to see all sorts of information that the parents told to their, and we tried to see if the medium could actually produce some information that could not be extracted or inferred by those information that the parents produced. Okay, so this is a case about Victor, a boy who died from leukemia with 12 years old in 2018. The next year, we had this seance. And the medium, they had first a short few minutes interaction, and then after that, the medium wrote a letter. During this meeting, the medium was in trance, allegedly under the influence of the deceased boy, and also after that, he wrote a letter. In total, during the meeting and in the letter, the medium produced 57 pieces of information, 57 pieces of information, specific information that could be tested and verified. We excluded the information that could be, for example, deducible. Like, for example, oh, the boy liked to play video game. 12-year-old boy is very likely to like video games, so it's not relevant. Right? So we exclude such case of information, the information that could be inferred by what the medium received of information. But in the end, the medium produced 30 specific and correct information that could not be inferred based on the information that he received from the parents. And let me give you some examples of these pieces of information. So as soon as the medium started the meeting, he was under the influence of the boy, and he started to say, why do I see myself on the pillow of a motorbike? And later we discovered that the boy was very ill, terminally ill at the hospital. And then the medical staff allowed him to have a weekend leave to stay with his parents for the last time before he needed to be admitted again to the hospital for the last days, the last care in the hospital. In this last weekend, they stayed together he stayed together with his parents, and he was, despite being very ill, he was a very happy boy, and he was very playful. And he said to the father, I'd like to learn how to ride a motorbike, a 12-year-old boy. And the father agreed with this last wish of his boy. And the last happy memory that the family had was the boy riding a motorbike and screaming and shouting, happy, and things like that. So in the beginning of this interaction, the medium brings exactly something that was very specific, very important to the family. And another example, the medium starts saying, whoa, I'm seeing a rose. Who is Rosa? Rosa is rose in Portuguese. And later we found that the patient, during his several hospital admissions, he took care by several women who had some names related to Rose. Rose, Rosilda, Rosalia, several different names related to Rose. They used to make a play to say to him that he was surrounded by Rose. So this was very specific. But two other more interesting aspects. One was when the medium wrote a letter under the influence of this boy. He started their letter this way: my dad and my mom, to unlock Vito. But this time, I don't need a password to leave each other, to talk to each other. We later discovered that Vito, that came from Victor, it's a nickname, was the standard password of the family for the internet or for their computers. So he started exactly writing down exactly what was the standard password of the family. And in the end, he also wrote, wherever I can, I play that joke. Frozen, clap hands. And of course, it didn't make any sense to us. But later, we interviewed the family and realized that, as I said, he was a very playful boy, and one he would like to make fun of his colleagues, of his friends. For example, instead of saying chicken, he used to say frozen, and then he clapped the hands. So it was a very, very specific way of his personality, of his way to make fun of people. In the end, also, he also drew this car, and then we later found that he was very fond of, he enjoyed very much drawing cars, and also to give it as a gift to everyone. See, in the right here, we have a car draw that he did in life. He did dozens of it. In the left, it is the one that he draw in his letter. So this is one example how the memory, the personality traits are preserved and could be communicated through the medium. And in the end, we also need to discuss the evidence for past lives memories. There are actually more than 2,000 cases registered in a scientific environment about memories of past life. And just to finish with this case is from Purnima. She was investigated in Sri Lanka by Erlendur Haraldsson. Purnima was in Sri Lanka, and when she was about 3 years old, she was seeing a TV program about a temple, Kelania Temple, a famous temple in Sri Lanka, and then she said that she had lived around this temple, and behind the temple there was a river, and above this river there was, as she lived there, she used to make incense sticks of brands Ambiga and Gitapicha, and these brands did not exist in the place where Purnima lived, and she was selling incense sticks on a bicycle. She was on a bicycle going to the temple to sell incense, and then she had an accident with a big vehicle. And actually, the investigators were there to the Kelena temple. They found a incense maker beyond the river, and this incense maker had a partner who was indeed with him doing incense of brand Ambika and Getapicha. And when this partner was in a bicycle going to sense incense sticks in the temple, he was hit by a truck, and then he died. So exactly, it fits precisely. And finally, the girl had some birthmarks, these hypopigmented marks her in the chest, the lower chest, and these birthmarks fit exactly the fatal wounds of the incense maker, because the tires of the truck passed through exactly this region of the incense seller body, and the guy died by the fractured ribs penetrating lungs, spleen, and liver. So exactly, so it's very precise, the information, very precise, the birthmarks. So the point is, these different experiences, near death, out-of-body experiences, reincarnation cases, mediumistic cases. They all are very different spiritual experiences, happen in different periods of life, and they all converge to one hypothesis, the survival hypothesis. Is the hypothesis that explains more easily and more naturally the total of the evidence. Of course, there are some cases of fraud, there are some cases of coincidence, but for example, in this case that we presented, is very difficult. So there is this convergence of the evidence for a very diversified and robust body of evidence about the persistence after death of the memory and character that makes up our personality. Okay, and these findings have been also replicated under strictly controlled studies by many of the most competent scientists of the last 150 years. And all these findings we have published in this book summarizing the evidence, Science of Life After Death, that has been translated in Spanish, German, and also in Portuguese. I'd like to thank you all for this opportunity. Here are my contacts. And also I'd like to invite you also to address our YouTube channel, TV Nupes. We have, Nupes is our research center in spirituality and health. We have at this channel more than 300 videos, bilingual Portuguese and English, covering the several areas about science, health, and spirituality by 80 leaders worldwide. Okay, thank you very much for this opportunity.
That was fascinating. We're going to keep the question and answer period till after Dr. Francis Liu has spoken. So thank you for that. It was absolutely fascinating. It is my honor to introduce Dr. Francis Liu, MD, MD-FAPA, who is the Luke and Grace Kim Professor in Cultural Psychiatry, Emeritus at the University of California, Davis. He is a Distinguished Life Fellow of the American Psychiatric Association. Dr. Liu, together with Dr. David Lukoff and Dr. Robert Turner, co-authored the proposal for the diagnostic category of religious or spiritual problem in the DSM-4 to help mental health providers with differential diagnosis of distressing experiences that involve religion or spirituality. And more than that, that this is not a sign of mental illness. In 2020, the Society for the Study of Psychiatry and Culture awarded Dr. Liu the Lifetime Achievement Award. And Spiritual Awakenings International has also recognized Dr. Francis Liu for his pioneering work as an honoree on the Spiritual Awakenings International Circle of Honor. We had awarded him back in 2020. Thank you, Dr. Francis Liu, for your groundbreaking work, and I'll now turn it over to you.
Well, thank you very much for that kind introduction, and I'm so honored to be in your circle of honor. And in the time that I have, I'd like to share with the audience, where do religion and spirituality appear in the DSM-5 TR? Now, for those in the audience who don't know what the DSM is, I will explain that in just a moment. I know there may be mental health professionals in the audience, but there are many people who are not mental health professionals that might be interacting with mental health professionals. So I think it's important for everyone to understand at least where mental health professionals can draw information concerning religion and spirituality. I have no disclosures. My email address is below, as well as a website to learn more about my work. The outline here is that I'd like to take a moment to acknowledge my own personal spiritual transformative experience, speak about the DSM history, and then go in depth concerning the DSM-5 TR. So at Esalen Institute in Big Sur, California, in May of 1978, I attended a 5-day seminar on Hinduism and Buddhism in Oriental art, led by Joseph Campbell. And on the last day of the seminar at Esalen, I experienced a very strong emotional, physical epiphany that my purpose in life was to bring together the East and the West. But what did that mean? And looking back now, so many years, I certainly believe that my work that I'll be describing is one manifestation, and also my 37 film seminars at Esalen Institute, 28 of which have been co-led by Brother David Stendelrast, a Benedictine monk. And I'll be leading a film seminar in July at Esalen. So the Diagnostic and Statistical Manual, which is the full name of the DSM, whenever we say DSM, we mean that. It's published by the American Psychiatric Association, and it is a classification of mental disorders. And for each mental disorder, there are specific diagnostic criteria, as well as a narrative description with different sections about what that mental disorder is. And this is a standard reference for clinical practice, education, and research in the mental health field. Now, relevant to our work here is that it can help clinicians answer this key diagnostic question when seeing patients. What phenomenon or experiences are signs and symptoms of a mental disorder, or related to one's cultural background, broadly defined, including religion and spirituality, or are transpersonal experiences like STEs? Now, there's a whole lineage of DSMs that go back to 1952, and each number refers to the edition. And in 1987, the text revision process started, meaning that the diagnostic criteria were essentially unchanged, but the text, the narrative descriptions, the introductions, and so on, were revised and updated. So as you can see, in 1994, we had the DSM-4, and that began a process of including cultural issues, including religion and spirituality, in the DSM. And this has progressed all the way to the DSM-5 TR, which came out in March of 2022. And eventually there will be a DSM-6. So we do have the opportunity to make changes for the DSM-6. By the way, the DSM is being revised constantly, and I'll show you an update on that. Now, in terms of the 3 sections of the DSM-5 TR, there is an introduction, and what's underlined here are the take-home points, and what's in yellow was added for the TR. So instead of cultural issues, we have cultural and social structural issues, bringing together those 2 areas. Then we have cultural concepts of distress, because patients come in with distressing experiences, and we have to try to understand what they are. And so there can be idioms of distress or chief complaints or cultural explanations, such as a supernatural cause, or a cultural syndrome, which is a clustering of idioms and causes and other features. An entirely new section is the impact of racism and discrimination on psychiatric diagnosis and how this was attended to in the TR. Now, in that new section, we have things like this: race is a social, not a biological construct, and that we speak about racialization or racialized identities as opposed to racial identities. And it's important to understand about racialized identities because they're strongly associated with systems of discrimination, marginalization, and social exclusion. Now, this is important. Other aspects of identity, including ethnicity, gender, language, religion, and I put that in yellow there to emphasize that, may also be the focus of stereotyping that can affect the process of diagnostic assessment. So if the clinician, for example, is not aware of these issues and has the thinking that hallucinations or ideas are delusional or psychotic, they could make a misdiagnosis. This is saying to clinicians that we need to guard against stereotyping in our diagnostic assessment. And that the bottom line here is that racism is a important social determinant of health, or discrimination also is an important social determinant of health, and that clinicians should make active efforts to recognize and address all forms of racism, bias, and stereotyping in their clinical assessment, diagnosis, and treatment. So that means there are two aspects to that. One is the experiences that patients have had in their lives where they have experienced racism or stereotyping or bias, but also in the clinical encounter when clinicians are working with patients, they have to guard against their own bias or their own stereotyping in working with patients. Now, in section 2, this is the bulk of the DSM, and we have here the narrative descriptions and the diagnostic criteria. But in the narrative sections, there are specific culture-related diagnostic issues sections and sex and gender-related diagnostic issues sections. More in a moment. And then at the back, there's a section entitled Other Conditions That May Be a Focus of Clinical Attention. These have now been renamed Z codes to align with ICD-10 instead of V codes. So if you turn to the index of the DSM on this page, you'll find, and you turn to the different disorders like alcohol intoxication. There is a specific culture-related diagnostic issues section, and in there is some discussion about religion as part of the differential diagnosis. And in all of these disorders, religion appears in those culture-related diagnostic issues sections. And here is an example that some religious and supernatural beliefs, such as evil eye causing illness through curses or influence of spirits, may be viewed as bizarre and delusional in some cultural contexts, but may be generally acceptable in others, and that hallucinations may be a normal part of religious experience in certain cultural contexts. So this is warning the clinician that we have to take into consideration these cultural contexts or cultural background of the patient in making to understand how much of this is a sign or symptom of a mental disorder or part of the person's cultural background. Similarly, again, in the index, you'll find that will lead you to these particular disorders. In the culture-related diagnostic issues sections, you'll find some reference to spirituality. Now, turning to that other conditions that may be a focus of clinical attention. This is all from the introduction to that section in section 2. These are conditions or psychosocial environmental problems that may be a focus of clinical attention or otherwise affect the diagnosis, course, prognosis, and treatment of an individual's mental disorder. And what was added in the TR at the yellow at the bottom is that these should be or may be part of the diagnosis if it plays a role in the initiation or exacerbation of a mental disorder, or if it's a problem that should be part of the treatment plan. But it's very important to remember these are not mental disorders. These are not mental disorders. So many of these conditions here relate to the social determinants of mental health, which you see in the middle. What's in yellow were 10 written about by Michael Compton and Ruth Shim in their 2015 book called The Social Determinants of Mental Health. And as you can see in the lower left corners, adverse early life experiences, or the ACEs, ACES. And just to the right, we have discrimination, social exclusion, social isolation. The 6 in white are new ones that they've added since 2015, such as in the upper right, climate change. Now, in this section, other conditions that may be a focus of clinical attention, there is this one. You see, this one ties in to that social determinant of mental health. And this is broadly defined. So religion is here, spirituality is not, but religion is here. So anti-Semitism. And also, I think perhaps some people in the audience may have also experienced discrimination because their spiritual experiences are misunderstood, and this could cause a problem here. And then we have, of course, religious or spiritual problem. This first came about in DSM-4, and I spoke about this at the conference in 2021, and that video is on the website, so you can get a deeper dive into this by going to that video. And that this is the definition that has stood from the DSM-4 30 years ago to the DSM-5 and also the DSM-5-TR. This is unchanged. So this is a category that can be used when the focus of clinical attention is a religious or spiritual problem. Examples include distressing experiences. That's the key word here, distressing experiences that involve a loss or questioning of faith, problems associated with conversion to a new faith, or questioning of other spiritual values, which may not necessarily be related to church or religious institution. Now, when Robert Turner and David Lukoff and I proposed this 31 years ago, we wanted examples of spiritual problems, such as specifically near-death experience and mystical experience, when that is a distressing experience. Now, again, very important to say that mystical experience or near-death experience is not a problem necessarily, but they are problems when the person is experiencing distress and go to a mental health professional. And so we wanted this category to be in the DSM so that mental health professionals can understand that kind of experience, not as a sign or symptom of a mental disorder, but as a religious or spiritual problem. But those two examples were not accepted for the DSM-4. Now, in an article that we wrote back in 1992, we felt that this would improve diagnostic assessment, reduce iatrogenic harm from misdiagnosis, and it's very important. You could have a mental disorder, or you could have a religious or spiritual problem, and then there is the possibility of both mental disorder and religious or spiritual problem. That's a very important differential diagnosis. Also, we felt that this would improve treatment by stimulating clinical research, such as what Alexander just presented, and encourage training in this area. Now, in 2010, a number of us did propose a revision for DSM-5 of religious or spiritual problem, and the beginning of this revision is the same, but we wanted to include new religious movements and cults, life-threatening and terminal illness. Specific examples of spiritual problem include mystical experience, near-death, psychic experiences, alien abduction, meditation, spiritual practice related, possession experiences, we wanted those examples in the definition to help clinicians. Unfortunately, the steering committee did not accept that, so we're left with the same definition as in 1994. Now, there is a 2024 proposed revision, which has been approved by the DSM steering committee and is pending review and approval by the assembly and the board, which is the process for all changes in the DSM. And that is to add a moral problem. What's underlined here is the proposed addition. And with the added sentence there, moral problems include experiences such as moral injury and moral distress that disrupts one's understanding of right and wrong or sense of goodness of oneself, others, or institutions. So the work that's been done with veterans who have experienced moral injury, or healthcare professionals, especially during the pandemic, faced with tremendous workloads, have experienced moral injury. And so the group that's been working on this, including myself in the later stages, felt that it would be important to include that in the DSM. So this, we'll see if this is finally approved. Again, so in my last 10 minutes here, I'm going to now go to the two tools which are in section 3, and that's the outline for cultural formulation, or abbreviated OCF. Again, this first appeared in the 9th appendix of DSM-4. It was revised for DSM-5, and it was revised for the TR. And I'm going to focus on that for the rest of my talk. In addition, in the DSM-5, a cultural formulation interview was introduced, unchanged in the TR, and this is a set of 16 questions to help clinicians gather the information for the outline for cultural formulation. And there's a cultural concepts of distress section, which expands on that. So these are the 5 parts of the outline for cultural formulation. I'm going to go over each part very quickly in just a moment. These are, when you say, what are the cultural issues in this case or for this patient? Well, here's an outline of things to consider. What's the cultural identity of the individual? What are the cultural concepts of distress? What are the cultural stressors and supports in the person's life? What are the cultural features of the relationship between the individual and the clinician? Added in the TR was treatment team and institution. And then the last part is given the information that you have obtained, how does that affect your differential diagnosis and your treatment plan? Now, in addition, as I mentioned, is the cultural formulation interview that came in the DSM-5, unchanged for the TR. Again, the 16 questions. And these are published in the DSM. There's an informant version that has an added question. Now, in addition, there are supplementary modules to provide deeper dives into particular aspects available at that website, dsm5.org. And in the right-hand column, I have yellowed religion, spirituality, and moral traditions. So these are the categories of questions. There are like 19 questions to help clinicians understand the individual's background in regards to these areas and how it might be related to the problems that they're experiencing in life. And so this is very important to pull out to help clinicians assess this aspect of a person's life. Now, I'm going to go over in the 6 minutes I have left here the 5 sections of the outline. What's in yellow was added, and what's underlined are the take-home points. So for the cultural identity of the individual, what was added here was spirituality. Do you see that in the center? Religious affiliation and spirituality are important aspects of the person's life. And note which aspects of identity are prioritized by the individual and how they interact, or intersectionality. These are very important concepts in understanding someone's cultural identity. The rest of it was unchanged. And here's a diagram to help you conceptualize this. If you look at linguistic characteristics at 8 o'clock and go clockwise to 5 o'clock, spirituality, you see how those different cultural identity variables intersect. And that's how we need to understand the complexity of someone's cultural identity. To prevent stereotyping, that's a major, major problem in our work. The next part are the cultural concepts of distress, and you can see the 3 subtypes are listed there. There's more added in the yellow to give more detail there. And that the last sentence is assessment of coping and help-seeking patterns should consider the use of professional as well as traditional, alternative, or complementary sources of care. So we're interested in Tai Chi, acupuncture, or spiritual healer, that these forms of care should be understood by the clinician. I'm just going to move on because of time. In the 3rd section, the cultural stressors and supports identify the key stressors and supports in the individual social environment. Very important was added are the social determinants of the individual's mental health. So these are the Z codes. We need to understand, if the person is experiencing any distressing experiences related to the Z codes, including religious or spiritual problem. And then it also adds in the next sentence, assess the role of religion, family, other interpersonal relations, and social networks in causing stress or support. And religion and family go back to the DSM-4 version of the outline. Spirituality is not mentioned here, but again, the role of religion or spirituality in providing stress or support for the person, that needs to be assessed here. Then the 4th part, the first sentence says it all, identify the differences in the cultural identity between the individual and the clinician. Treatment team and institution was added that may cause difficulties in communication and may influence diagnosis and treatment. So again, if a clinician doesn't believe in spirituality or religion, is an atheist, and asks, well, what brings you here today? And the patient says, well, I've lost my faith in God, or God is punishing me for my sins. There's a difference there in religious or spiritual orientation, and that could cause a problem if the clinician is blind to the patient's background or what troubles them. It can lead to a real rupture in the patient's relationship with the clinician. And experiences of racism and discrimination in the larger society may impede trust or safety and may impact on the therapeutic relationship. So this is a very, very important area, and we still have a long ways to go, in my opinion, in terms of mental health professionals being aware of this aspect of human experience. And this is the last part. Is the importance of summarizing all of this information. How does this impact on our differential diagnosis of mental disorders and the other clinically relevant issues or problems? Those are the Z codes, such as religious or spiritual problem. And then how does this impact on the treatment plan? So we always want to make a accurate and complete diagnosis. We need a complete differential diagnosis. Misdiagnosis leads to mistreatment. If we if someone has a spiritually transformative experience and it is misdiagnosed as a psychotic symptom related to a psychotic disorder like schizophrenia, that's a misdiagnosis, and that could be due to many of the reasons I've listed here. And that could lead to mistreatment, and that's a big problem. So how do we deal with this? Well, we need to look at the culture-related diagnostic issue sections that I pointed out earlier. We need to add and look at the Z codes, such as religious or spiritual problem, as well as the other Z codes. And we need to use our two tools, the outline for cultural formulation and the cultural formulation interview, to help us here. And in fact, this impacts on the treatment plan. How do we negotiate and manage a treatment plan to maximize adherence and compliance? And looking at how this affects the different elements of our treatment plan. In terms of resources for further learning in this area, I recommend Spiritual Competency Academy, which David Lukoff has worked on with Cassandra Vithem, and they have courses that go into this area. The Society for the Study of Psychiatry and Culture, the World Psychiatric Association, Alexander mentioned earlier, and the American Psychiatric Association. There is a mental health and faith partnership website there. Also, in terms of books around the outline for cultural formulation and the cultural formulation interview, as well as an online training on the cultural formulation interview. So thank you very much for your attention.
Thank you both to Dr. Francis Liu and Dr. Alexander Almeida, Moreira-Almeida. I believe Moreira comes before Almeida, for your incredible presentations. As for those of you in the audience who are not healthcare providers or not a physician, I just want to say before we get to the questions, and please put your questions in the chat, that the work both of you are doing is so very, very, very important. And, you know, that I bow to both of you with deep respect for being pioneers that you are. And I shared with Dr. Liu when we were chatting at his rehearsal meeting that when I was trying to begin to specialize my medical practice here in Canada back in the 90s in counseling patients with spiritually transformative experiences, I had a lot of hurdles to go over in the medical profession, and I could theoretically have lost my license. You know, I was asked to prove what counseling STE experiencers had to do with the practice of medicine. And, you know, and people were not pleased. Some people were really not pleased that I was going in this direction with my specialty. And through the grace of God and the invisible fingers that work from the other side helping us, I had just met Dr. Robert Turner, who collaborated with Dr. Francis Liu and Dr. David Lukoff on preparing this category. And so I was aware that they'd done the submission and it had been approved before it was even public knowledge. So when I was like being grilled about how is this related to the practice of medicine, I was able to say, oh, very nonchalantly, perhaps you're not aware, but this has recently been approved by the American Psychiatric Association. And so thank you that you played a huge part for Dr. Liu in making it possible for me to do the groundbreaking work that I did. You had to do the groundbreaking before that. Anyway, with that being said, that was a comment, and you're now sort of like the next younger generation. Dr. Moreira-Almeida taking over from Francis has been really on the front line of this for the last 30, 40 years. Anyway, we have a number of questions, so I'll finish with my content and my comments, but I wanted to say just how important that work is. And so let's see here.
Yvonne, may I just make a comment about
Professor
Francis Liu? Yeah, he was also very important in my own career also. When I was a psychiatry resident in 1998, and we started a research group in spirituality, the first in Brazil, one of the major supporting reference was exactly the religious and spiritual problems from DSM-4. So it opened a lot of doors also here for me in my career. So I'm very, very grateful to Dr. Francis Lu.
Mm-hmm. Thank you for saying that. Yeah, I just want everyone in the audience to know this was really, really important work that Francis did, Dr. Lu. I'm going to go to some of the questions, and we have a question here from Valerie. Are mental health insurance companies paying when people have a Z code diagnosis? Dr. Lu, maybe you could answer that one.
Not in the past, but it is changing because there's more and more research that clearly shows that paying attention to Z codes can lower the cost of care. So, for example, housing insecurity or food insecurity, those are major Z codes. And research has shown that if clinicians pay attention to those Z codes and puts it as part of the treatment plan on trying to resolve those issues, that it has a bottom line effect on healthcare costs. And so the federal government and insurance companies, managed care companies are beginning to pay attention to these and reimbursing for care. Now, in terms of religious or spiritual problem, I'm not aware of how that's being handled on this front. I doubt whether there is reimbursement for it. But again, if we can do the research that shows that paying attention to this makes a difference financially, that would be very useful.
Mm-hmm, mm-hmm. Thank you, Dr. Lu. The next question I'm going to give to Dr. Moreira-Almeida. And the question is, in your experience, are some countries more open to considering spirituality and mental health than other countries? And if so, which ones? Mm-hmm.
Yes, I think it varies between countries. Actually, we see that the population as a whole has interest in discussing the spirituality, but sometimes the medical, the academic environment sometimes has more resistance. For example, I've heard from several colleagues in some European countries, for example, in France, that they had some problems in integrating and in discussing these topics in their countries. For example, in Brazil, it has become quite open to this kind of discussions. So definitely it varies. And also the awareness of the mental health professionals about the evidence available in the topic. Also, it varies a lot. And the important works that have been performed, for example, in the sections of spirituality from the Royal College of Psychiatrists in UK, from the American Psychiatric Association in the US, have been also very important in spreading the information to the mental health professionals.
Mm-hmm, mm-hmm. Thank you. Yes, our next question is for Dr. Lu. That's actually from another of our Circle of Honor honorees, from Dr. Emma Bragdon. It's this question. And Emma is asking Dr. Lu, please share with us what response you got from the DSM editorial board in 2010 when they refused the revisions that you submitted. Especially, what did they say regarding mystical experiences? And last but not least, thank you for your wonderful presentation, Dr. Lu.
Well, thank you, Emma. Emma and I go back all the way back to 1980 when both of us were at Esalen Institute, and I applaud your work enormously. Thank you very much. Well, honestly, I don't really recall what their response was. Um, I really don't remember. I don't know if we got much of a response at all, but in any case, there seems to be a reluctance to put near-death experience or mystical experience, which has a tremendous amount of literature as well as many of the other things that we mentioned in the DSM. Now, there's always hope that in the DSM-6, maybe we can mount another effort. The fact that they've included moral problem, including moral injury or moral distress, I think shows at least a willingness to look at the definition. And so we can only hope for a change.
Thank you. We have the next question is for Dr. Moreira-Almeida, and the question is, did you mention that the more educated an individual or society is, the more likely they are to believe in spirituality and reincarnation? What do you attribute that to?
Yeah. What I mentioned is that sometimes people believe, or it's assumed, that the higher educational level means lower levels of spirituality and also lower levels of acceptance of some type of survival after death, of afterlife. And there are some studies in different countries showing that, at least in some countries, it's the opposite. The higher the frequency, the higher the educational level, the higher the acceptance of some sort of life after death. So there are national surveys in Brazil, in Canada, in Russia, and in France showing that this is the case. And the reason, well, I don't know. There are several possible explanations for these correlations, but it's also important. Some countries, there is no correlation. For example, in Japan, there is no correlation between educational level and lower levels in afterlife belief. So the first point is, it's not true that usually the higher the educational level, the lower the afterlife belief. That's just a belief from people low educated that has no contact with scientific information, things like this is wrong. Now, the reason why higher educational level can be related to higher afterlife beliefs, I think it deserves further investigation.
Thank you. That's a fair answer. Deserves further investigation. I would like to ask Dr. Liu to answer one of the questions I asked Dr. Moreira-Almeida, which was, what is your experience about certain countries or certain regions of the world, or people from certain cultures even being more open to spirituality in the afterlife?
I would defer to Alexander on that with his wonderful book on surveying this throughout the world. I would say that, I'm just thinking off the top of my head that places such as India or Japan, where Hinduism or Buddhism are predominant religions, those religions do certainly have beliefs that involve reincarnation or afterlife, that there's greater openness there.
Okay. We have a comment, and I don't really understand the comment, but I'm going to give it to Dr. Moreira-Almeida because maybe you will understand this comment. Rita Ortiz says, all collectivist cultures are more open to spiritual experiences, and some apply certain practices in the clinical area. Professionals respect it more than in Western cultures. Do you know what she's referring to?
I think because I think it may be because some cultures are more oriented to individualistic approach about the development of the own person, and some other cultures are more collectivist that think more in a group. Each culture has its advantages and disadvantages in this sense, but I'm not sure. But perhaps this more collectivist culture have more openness to spirituality, and also in regarding how the academic environment deals with spirituality. There was a very recent paper published at the journal Nature, last month, showing that scientists throughout the globe deal in very different ways regarding spirituality. For example, specifically scientists in France and the UK sometimes have more difficulties in making connections between spirituality and science. But on the other side, scientists from India, from Italy, are more open to make these integrations. So definitely the cultural background and even the intellectual environment in each country influences the openness of scientists or mental health professionals to integrate this approach. But I think one of the most important aspects is exactly to overcome prejudice, to present good data, good scientific data, showing the importance, the prevalence, and even the good empirical scientific evidence about the existence of these experiences. And I think this will overcome many of these resistances.
Mm-hmm.
I think it's important when assessing, an individual, to keep in mind what aspects of identity are prioritized by the individual and how it intersects in terms of how does it intersect with all of the other cultural identity variables in the clinical assessment of a person. Because stereotyping, overgeneralization, can be a real problem. And so, yeah.
Great. Thank you to both of you. Thank you, Dr. Francis Liu. Thank you, Dr. Alexander Moreira-Almeida, both of you for your groundbreaking work that you're doing. Please keep it up. And thank you for your wonderful presentations today. It was an honor having you both speaking with us today.